Thank you, Olivia, and welcome everyone to today, October's Pharmacy Access Offers Hour session. Really excited about this topic. What's your capture rate tools for growing your in-house pharmacy? I'm pleased, and hopefully I met several of you at our first hybrid Phar IT conference last week. We tried to push this session there too, so it seemed to have worked. We had a really exciting response for registration, so a little over 450 people registered. So we'll let people continue to join us. I see the attendee number going up. All right, so let's move on to our next slide. So as always, as office hours are supported by federal funding, we are prohibited from discussing any advocacy-related discussions in this forum. So just a gentle reminder. Next slide, please, Olivia. Okay, for today, I'll make it really quick. We'll be doing a quick welcome and overview, and next I'll allow my colleagues to provide state affairs and federal affairs updates, so you'll get that shortly. Our speakers are coming from 3 different health centers: Karen Dan at Jericho Community Health Center, David Christian with Central Virginia, as well as Keith Sine with Health Point Community Health Center. So we're excited about their highlights during the session. And then at the tail end, again, as Olivia mentioned, we have a Q&A tab at the bottom of your Zoom player. So feel free to load some of those questions into the Q&A, and we'll also be monitoring the chat as well. So we'll try to capture your questions both ways, but if you could get them into the Q&A, that would be much easier for us to kind of monitor on the tail end. Next slide, please. All right, so I'm just going to hand things over to my colleague, Jeremy Crandall, to provide a state affairs update, and then he'll lend it over to Vicharia. Jeremy?
Great, thanks, Brandon. Can you hear me okay?
I can.
Awesome. Good afternoon, everybody. So yeah, Jeremy Crandall, I'm the director of the federal and state policy team here with NAC. My update's going to be relatively brief, but I definitely want to make sure it's on everybody's radar screen. So we've been looking to more actively engage on state-based 340B policy issues for the better part of this year. And one of the things that we've been doing is trying to see if some of there's I call it an alphabet soup, if you will, of acronym type state-based groups: NCOIL, NCSL, NAIC, ALEC, NGA. I will stop there, but I could do another 6 or 7 if I wanted to. But really, the one thing that all these groups have in common is they're collections of various state level policymakers, state legislators, governors, insurance commissioners, and other stakeholders, electeds or appointed office holders that come together and work on policy and put together model legislation and generally just work on a considerable amount of health policy issues. One of the groups that we've really centered in on is called NCOIL, the National Council of Insurance Legislators. They are a group that meets 3 or 4 times a year. They are very focused on prescription drug issues. I used to lobby them in a previous life for a former job that I had. And I can tell you for the better part of the last 4 or 5 years, they have been talking about PBM reform, prescription drug transparency, and just a number of issues related to prescription drugs overall. And so we've been, I shouldn't say lobbying, we've been poking them because we're not lobbying because it's not a state legislature, but we've been advocating or poking them, I'll just leave it at that, to talk about 340B, to essentially have it on their agenda, because they're a group, again, that meets outside of their normal legislative process, along with these other ones, and they consider a range of issues. And one of the issues that they haven't considered in all the time that I've been engaging with them is 340B. In the 2 or 3 years that I went to their meetings, never once heard those 4 numbers and letter mentioned when they were talking about prescription drugs. And so what I'm excited to announce is that in about 3 weeks at their November meeting, they are going to be having a panel on 340B. It'll be myself and then most likely a representative from 340B Health as well. I do not know if other stakeholders, whether from the PBM universe, the health plan universe, or otherwise, will be presenting on 340B. But the reason I wanted to let you all know that is that there are a wide range of legislators that are active with this organization. And so what I'm going to do is just put in the chat the committee that that I'm going to be presenting to about 340B. If any names catch your eye, if your health center or your state association engaged with any of these folks, please let me know. And just generally, we want to continue to ramp up the awareness of 340B with this group and then other groups as well. So again, panel is going to be in about 3 weeks. Generally, just want to make sure you all know that, want to make you all aware that this is happening. And then if you just generally have ideas or thoughts or would like to talk more about engaging with some of these groups, please let me know. But otherwise, we'll let you know how it goes and stay tuned. So with that, that's all I have. And I'm going to turn it over to Vasharia Tutson from the NAC team.
Hey all, I'm Vasharia Tutson. I'm the Director of Regulatory Affairs here at NAC. I oversee a lot of our 340B work and also our litigation. So I wanted to provide you an update because a lot has been happening with our ADR litigation suit, and definitely in a good way. We're finally starting to see traction. So next slide, please. So at the beginning of this month, HRSA notified NAC that they had finally referred our ADR petition to a panel of 3 members from the ADR board. And this petition is against Sanofi and AstraZeneca. Eli Lilly has a preliminary injunction against the ADR rule, which means that our claims could not move forward against Eli Lilly until their litigation is resolved. And so in true form of all the litigation going on, Sanofi did not want to comply with the ADR process and filed a motion for emergency relief in their court case to not have to comply with the ADR process. Their judge actually denied that emergency relief and said that they needed to move forward with the process. And so at that same time, also, I think a few of you probably have heard about Calderos filing their lawsuit against HRSA, challenging their authority to prohibit manufacturer conditions on the 340B price. And so that's specifically surrounding Calderos wanting to switch to a rebate model instead of upfront 340B savings. According to Calderos' petition, they claim that they had been in conversation with HRSA on and off for a few years, talking about their rebate model. They felt that the OPA was not receptive and was blocking them and manufacturers in a way that HRSA does not have the authority to do so. As we know, Calderos' model would be detrimental to the 340B program because it would also rely on manufacturers providing those rebates, which we can see that there's not really a trustworthy relationship at this point, and that would be very risky for health centers to, number one, purchase drugs at cost up front, and then hope that manufacturers on the back end would provide a rebate. So we are definitely monitoring the Calderos case and to make sure that the health center perspective will be represented in the best way possible, but our litigation is also still moving forward. So since Sanofi claim was denied, next slide. Since Sanofi's claim was denied, the ADR panel finally issued their initial scheduling orders, which requires Sanofi and AstraZeneca to update the court within the next 30 days. And so the reason this timeline is really important is because when the Sanofi judge denied Sanofi's emergency relief to not comply with the ADR process, they did say that they will issue a ruling by November 5th, which is next Friday. So within the next 30 days, Sanofi will know for sure, and we will know for sure if the ADR rule is held up valid in that court case, if HRSA has the authority to send the violation letters that they sent earlier this year in May, and then also if HRSA has authority to refer the manufacturers to the OIG for civil monetary penalties. So this next 30-day process is great to see that the ADR process is moving along. On this slide, you can see the 3 members that were assigned to review our petition. So the panelists that are going to be overseeing our petitions. So we will know definitely a determination in the Sanofi case. The reason why the first lawsuit judgment is very important is because it will set the tone for the 6 other manufacturer suits that are out there. So currently we have a list of Sanofi, Novo Nordisk, Novartis, United Therapeutics, AstraZeneca, Lilly, and then Pharma, the trade association, all have lawsuits right now against the ADR rule and the violation letters that HRSA sent in May. So we are at kind of the crossroads and really tipping point of our litigation. majority of the cases are ready to issue a ruling. And so we just know for sure the Sanofi judge will be coming out with something in the next week. So this could go multiple ways, but our best case scenario is just the Sanofi case rules in the government's favor, saying that they do have authority to require manufacturers to ship to contract pharmacies, that the 340B statute includes using contract pharmacies. And I see someone mention the Boring, I hope I'm saying that right, the Boring case. That one doesn't necessarily apply to covered entities or to health centers. So that's why I didn't mention that one, but that was also newly filed in the last few weeks as well. And that's really targeted towards hospitals. But we will find out how the 340B statute interprets contract pharmacies, and we are hoping that they go in the government's favor of saying that, yes, it does not explicitly say contract pharmacies, but the way that, covered entities like health centers can carry out the 340B program is through contract pharmacies, especially if a health center cannot afford to have an in-house pharmacy. Also, we need them to say that the ADR rule is valid so we can move forward, because that is the only remedy for a covered entity to be able to bring a case against a manufacturer for overcharging for the 340B price or not making that price available, which is what our petition really gets at. So the Sanofi case will fall first. We are very hopeful and supportive of the government's position. A worst case scenario, or maybe a true scenario that could come to play, is that we get multiple judgments in these 6 lawsuits. And so what that could mean is that in one jurisdiction, we know for sure you can have contract pharmacies, but in another jurisdiction, maybe not. And so that would be worst case scenario, because we clearly don't want to see different authorities being extended depending on what state you're in, if you can use a contract pharmacy. But unfortunately, because the lawsuits are ranging from New Jersey, the DC Circuit, Delaware, and Indiana, we could kind of be all over the map in how the judgments turn out. So we're hoping that this first case sets a strong precedent in the government's favor, and that the other judges will use that to make their decisions and side with the government, which is how it should go of their interpretation of the statute and the program. So if we get a judgment in our favor, that means that under the law, manufacturers are required to ship to contract pharmacies. That means that it might take some time for this to play out and for them to resume shipping, but that gives HRSA the authority to fully maximize whatever repercussions they can under the 340B statute to a manufacturer who still will refuse to comply. So that means that HRSA could go nuclear and say, either you comply with the 340B statute, or you cannot be in Medicaid any longer, or you cannot be in Medicare any longer. And they would have that authority because they have judgments that prove that HRSA's interpretation is correct of the 340B statute. So, HRSA has definitely extended as much as they can under the statute. Unfortunately, their hands are tied regulatory-wise of much more they can do besides sending violation letters and referring the manufacturers to the Office of Inspector General for civil monetary penalties. So we really need the court cases to solidify that HRSA has this authority and can extend it further. So we will definitely continue to monitor the litigation. Over the last year, we have submitted amicus briefs and definitely been upfront. The reason why we didn't we oppose the manufacturers asking for an extension in our ADR process is because we've been doing this for 10 months. So they don't need another 30 days, and we need this process to move us forward as quickly as possible. Actually, our next, we are meeting with the court today for our ADR litigation against the government. So we are hoping that when we talk to our counsel later today or tomorrow, that they have an update for us from the government on their plans of making sure that this ADR process continues to move forward. So I know that this has been a long process, and I spoke a lot of legalese to you guys. So I'm going to put my email in the chat box if you want to talk about this further, or you would like me to speak with your health center or anything else. And if you have any more questions about the litigation or the state of play of things, just feel free to reach out to me with any questions. So thank you.
All right. Well, welcome everyone. It's great to have so many of you online today. This is a topic that I've been excited to have presented. I've been thinking about this for about a year, and have been able to put together this panel of speakers that I've met through different opportunities or I've heard speak on this before, but I wanted to get us three different views on expanding your in-house capture. I found that there were health centers only capturing 15, 20% of their prescriptions written at the site. And I was very concerned about that. So my goal today for all of you is that you'll be able to walk away with some real hands-on tactics to start expanding your program and getting more of those prescriptions. So before we get started, I had just a couple of Nattlepod updates. I'm really sorry for the picture, everyone. It's frightening, but it's the best way for me to show this to you. I would like for you, if you would, if you're members of Nattlepod, if you're not, please reach out to Brandon or myself and we'll help you get part of Nattlepod. But I would like for you to add your location and the health center that you're with. Next slide, please. So after you edit your profile, you can enter in your job title and the location. And if you choose to put in information about yourself or your skill sets or what you do at your health center, feel free to. But I think it's real helpful as people may read your posts, they can look at your profile and go, oh, wow, they're a border state to me. I may want to reach out to this person and ask other questions. So if you could do this, I think it would help us all out so that we kind of know what part of the country are you from. If you're having a specific issue, it'd be good to know, is this universal? Is this limited to Arizona or the Southwest or something like that? Obviously, this isn't a mandate. It's not anything you must do. It would just be something great if you could add that to your profiles. So that's all I wanted to present. And I really wanted to get done quickly because I wanted to give our speakers plenty of time and I wanted us to have time at the end to ensure that your questions are answered. So we're going to start off today with Karen Dan from Jericho Community Health Center in New York. And then David Christian is in Virginia and Keith Sine is in Washington State. All of them have a different technique and style to present to you. And as Olivia said, the slides will be available. They should have been emailed to you, and I'll also post them on Nattlepod for you. So if you want to look at some of their reporting and their techniques closer later on, you'll be able to. So without further ado, I'm going to go ahead and turn it over to Karen Dan.
Good afternoon, everyone. My name is Karen Dan, and I'm the Director of Pharmacy here at Jericho Road Community Health Center. Next slide, please. Jericho Road Community Health Center, we are high quality medical care for the whole family, especially those with obviously limited access to medical care. We especially focus on individuals that are refugees, immigrants, asylum seekers in this area. We have 5 clinical sites in the Western New York region. We also have multiple global sites in Sierra Leone, Democratic Republic of the Congo, and also Nepal. And we help to service a lot of really, really great programs through Jericho Road. We help to support these programs. One of them is our Hope Refugee Drop-In Center, receiving new refugees into this area. Priscilla Project, which helps to support women, pregnant women, postpartum women for labor delivery, breastfeeding support. Our Parent Child Plus program for literacy program and support for families, preparing children for school systems. And then Vive Shelter, which currently I think we have over 120 residents of. It's a shelter specifically for those seeking refugee status in Canada, and then also asylum seekers in the Western New York region. So we do a lot of really, really great work. Next slide, please. Our in-house pharmacy, a little bit of background. We operated through a contract agreement, through a contract pharmacy. It started off as a basic contractual agreement, and then we kind of expanded out and grew that program. This was prior to my time here at Jericho Road. And so we had staff that actually operated out of this contract pharmacy. And then we ended up opening our on-site pharmacy in June of this year and transferred that portion, the prescription filling that we were filling through this contractual agreement to our in-house pharmacy. So prior to opening, we also already had a substantial volume that we were already filling. Right now, with one pharmacy, our total monthly script volume is about 13,000, almost 14,000. Staffing, we have a pretty robust staff of 8 pharmacists. That includes myself, and we also have a clinical pharmacist on site, 10 technicians, and a 340B compliance administrator. Currently, our penetration rate is only 24%, but now that we have our in-house pharmacy, we have a substantial capacity now to actually grow. So this is actually going to be a targeted approach that we will start to use in the an approach that we used previously, and then an approach that we're really going to start using in the next few months. We have a lot of providers here. We have a very large family residency program, 43 total prescribing providers, serving about 23,000 patients in 2020. And we're going to be approaching, 90,000 visits even this year. So next slide, please. These are a lot of the pharmacy, clinical, and dispensing services. So opening an in-house pharmacy, there's going to be a lot of just internal promotion for your pharmacy services. Patients are being seen maybe right in the same building or clinical site that you're located in, and providers definitely will want to send patients to you. So a lot of the patients that we end up servicing more so than some of our other pharmacies would be patients that are obviously eligible for sliding fee scale, uninsured, any new refugee that we start servicing with our primary care services, our asylum seekers, especially those that are residing at VA. And because we have so many clinical services, we have patient visits for teach consultations, adherence measures. We also have compliance packaging. We have 100 patients enrolled in that for Medipacking. And seeing patients that obviously have transportation access barriers because we offer free delivery services, and those patients with complicated disease state management. So this is the basic growth and that you'll see with your pharmacy. So the targeted approach that I'm going to talk about is expanding beyond this because these are the patients that you're typically are always going to see. Next slide, please. So our in-house pharmacy growth process, we've done this a couple times as we were operating through our contract pharmacy. And this kind of approach started with this creation of, we have a basic financial report that we created in our pharmacy software system. And it gives a lot of information on it. But the main thing is we're trying to look at medications that have high margins. So we take, the columns in this Excel generated report out of our pharmacy software, and we take that third-party revenue, subtract the drug acquisition cost from that, and you get the margin on your medication. This allows you to give more of a targeted approach. So in order to service, all of those patients that are uninsured and sliding fee scale, and the patients that are not going to necessarily generate revenue, we help to service those and those programs by obviously, billing to third party and the medications that we actually are getting a high margin on. So that kind of is the basis for this type of approach. Taking this report, what we ended up doing is sorting this report from highest to lowest margin, and then set your margin cap value at whatever that value might be. So we started with a value of $500. So any medication that we were making a $500 margin on and above, and making sure that we were making our best effort and trying to capture those patients for using our in-house pharmacy services. And then once, you kind of go through and have this targeted approach, then you can kind of modify that margin cap level. So we got to a point that we were targeting medications that we were having a margin on of greater than $100. I took this, so then I would take this medication list, I submitted it to my data specialist, who's our director of health information, and she's the person that actually does all of our reporting in MedDent or our EMR system. And she created a MedDent report that has specific information on it. And she sorted this report by any individual that was using an outside pharmacy as a primary pharmacy, so not our in-house pharmacy, and then had at least one of these high margin medications on that list, and created this MedDent report so that we can actually open up this report, review this report, and then try and connect with these patients to make sure that we were touching base with them and promoting our pharmacy services to them. I just mentioned about the specific columns on the report and the links that you can get to on the report. So I'll walk you through that. Next slide, please. So this is kind of like the basic structure of the report. Prime language was an important column for us to have. This patient's primary language is Quran. Most of a good portion of our patient population doesn't have English as a primary language. So it's really important that we utilize our in-house interpreter team in order to connect with patients. That section where it says name and it's underscored, you can actually click on this patient name and it takes you right directly into the patient chart. So it allows you to, view the patient chart, see if there's opportunities there, and get a full picture of the patient. Now, that high cost drugs, there are some limitations with the EMR system. So this says 14 high cost drugs. This patient is not on 14 high cost drugs. But sometimes the filtering, if a medication is, discontinued and reassigned, sometimes it would get filtered in this report. So this patient, it had 14 listed, but some of them were duplicates. So Stiglatro was listed multiple times. So this is when we were actually sorting the report for revenue greater than $100. And this patient is actually on 3 high cost or high margin medications and wasn't using our pharmacy. So we wanted to make sure that we were connecting with this patient. And then there's the last appointment column, which we used last appointment, but you could also create this report and sort it by next appointment date. And that would be really important for the in-person model. Next slide, please. So 2 models. We conducted at one point a phone model and then an in-person model. So the phone model was actually when we were operating through our contract pharmacy. This model was actually conducted by non-pharmacy staff, some of our staff that was furloughed during the COVID-19. And so a lot of this was members of our nursing team and things like that were working at home and were helping with a lot of other departments. So we created this report, which was a pretty robust report at that point. And it really helped during the pandemic with really supporting like the financial solvency of this organization. So this at-home staff would call patients over the phone and offer their pharmacy services from this report. What was really beneficial about this is it allowed a lot of patients to start using our pharmacy, especially those that had delivery services needs. It allowed us to use our interpreter team more extensively because we were able to connect over the phone, and you can call on a conference call directly with our in-house interpreter team. And then we were able to conduct this during more convenient times. So not in the midst of dispensing, but after hours or in the evenings when a lot of individuals are home. The shortcomings of this type of phone model is that there's no face-to-face interaction. You're getting a phone call from somebody from the organization. And then we were using non-pharmacy staff. So sometimes they weren't able to answer all patient questions, and then they would have to connect with somebody from the pharmacy. And both shortcomings of either one of these models is you have to have a fill history first. So when you open your in-house pharmacy, you're going to have that initial growth, and that's just natural for having the pharmacy on site. And then once you have, maybe a few months of filling under your belt, then that's when you want to start generating this report to actually really start capturing those medications that you're making high margin on. Our other model is an in-person pharmacist-driven model. And this is when we would connect with patients during their next appointment. Benefits of this model is you're meeting with the staff face-to-face. You have the opportunity to walk that patient directly to the pharmacy and show them the pharmacy space, exactly where they're going to get their medications filled, especially if they're using the delivery service. This is an opportunity to give an information leaflet to a patient, especially if they're on the fence of changing pharmacies, or just to give them that informational of all of the services that we provide here for pharmacy. And then it's a great opportunity for pharmacists to do a lot of those clinical medication reconciliation, answer any questions during that patient visit, and really connect with the pharmacist team. Our pharmacists are considered providers here in our organization, so it allows them, and it gives that strong collaboration between provider and pharmacist. Shortcomings of this is sometimes patients are caught a little off guard. Why is pharmacy coming to talk to me when I'm here to visit with the doctor? So, sometimes that's a little bit, it's got to be a kind of a soft handoff. There's obviously time constraints with the dispensing team, especially if you're a high volume pharmacy, being able to look at the patient visits for the day and say, oh, I have to meet with these patients, and finding time to, remove yourself from the dispensing. We have less interpreters on site available. So a lot of our interpreter team, they're helping other patients during that time. So to get pulled from the dispensing to go into the patient visit and then pull an interpreter potentially in there, there's some limitations, with that. And again, the shortcoming of both of these models is you have to have a fill history to generate this MedDent report. Next slide, please. And this is the final steps. Especially if you use like a phone model, which it doesn't have to be excluded to non-pharmacy staff. It can certainly be pharmacy staff that's doing this. We would create a triage in our MedDent or EMR system. We had a template for it. If we're unable to connect with the patient, or we had to leave a message, that way when the patient calls back, that we're not searching around of why this patient was called. So there's, a template in there to say, this is, I want to talk to you about our in-house pharmacy. These are some of the services that we offer, et cetera, et cetera. And then if a patient agreed to wanting to switch to our pharmacy and was really interested in using our pharmacy services and really wanted to help support the organization through our pharmacy services, we would simply change the primary pharmacy in MedDent, send triages to our in-house providers to send over new scripts to the pharmacy, and then also with patient permission, using SureScripts or their medication list in the chart, and reaching out to any, outside providers. This is really important, especially if you're using a referral progress note model for 340B pricing and have a strong referral list. For that, this really helps to, especially with targeting patients that have, endocrinology, neurology, some psychiatry type referrals. So this really helps to capture some of that referral optimization as well. So thank you so much.
Oh, thanks. Hey, Karen. Good afternoon, everyone. I'm David Christian. I am the pharmacy director here for Central Virginia Health Services Pharmacy. As for Central Virginia Health Services in general. Next slide, please. Just a little bit about us. We were the first health center in Virginia. Ms. Beulah Wiley, who is pictured here in 1970, without any assistance and no real legal background for her, just saw a need in the community and went to Washington and said, somebody has to do something about this. And what we discovered was in the two counties that she was helping get folks from where they lived to the closest primary care was about an hour away, and she was helping a lot of folks at that time. So she did this basically on her own without any prior education on how to get to that point. She also became our first director. As of 2021, this year, we now have 18 service delivery sites. We have another service delivery site coming on board here in the next quarter, which will put us at 19, and we do have one administrative site. We were the first health center in Virginia. We're also the first health center to have offer behavioral health. And just a little aside on that, the reason we were able to offer behavioral health is because of pharmacy and the capture and the utilization of 340B revenue, quote unquote savings. So Virginia's first full-time school-based center. We just opened that last year in the midst of COVID. So that was a real soft opening. We opened it up and then they shut the schools down. So and they finally went back to school this year, and it is working as designed. Next slide, please. So just to let you see what our footprint looks like, we are very dispersed across the state, covering about a third of it. Next up. Next slide, please. So just a little bit about CVHS pharmacies. We were included in the original grant, of course. It looked a lot different then than what it is now. We added our second pharmacy in our Petersburg location in 2004. We currently have 13 pharmacists, and they will be anywhere from administrative to operations, which is what we call our filling pharmacy, and then clinical pharmacists. With them, we have the ancillary personnel, which are technicians. We have 16 of those that help with operations and clinical. We do have, and I didn't list it here, 2 other employees that help with the 340B compliance of our programs. Just a little volume here in Buckingham. We have 2 sites, 2 in-house pharmacies, one in Buckingham, which is my offices, and then one in Petersburg. And I won't go through all of these, but total of about 165,000 prescriptions a year we dispense annually between the 2. We do mail out a considerable number of prescriptions now. As a matter of fact, we just got fully accredited yesterday. We got our final notification from URAC as a specialty pharmacy and mail order pharmacy. So we're excited about that. And we're mailing out approximately 80,000 prescriptions a year now from our locations. And the reason I say that is because that's where some of our growth is from. Next slide, please. So how do we serve our patients? In clinical pharmacy, we do so through, we do the administrating of Medicare annual wellness visits. We can't bill them. We're not recognized yet as providers. However, we do all the work, and then we invite the provider in for questions. We promise them that they won't be in there longer than 5 minutes, or we'll come in and give them the hook, and then they bill out that encounter. We do that inside of the clinic so that the providers don't have to migrate all over the facility. We also offer chronic care management, and those patients are enrolled by the providers. Currently, we have about 60 patients that we follow on an ongoing basis monthly for that. We have started some of the programs that were initiated by pharmacy and now are still pharmacy-run programs for our organization. The first was hepatitis C. So we recruited one of our newer providers at that point in one of our sites. They partnered with us as we built out this Hep C program. And so that has now gone from that one site and the pharmacy to we're offering hepatitis C treatment in 9 of our 18 locations. Why is it important that it's pharmacy driven? Is that we handle all of the PAs, which is on every prescription. And the doctors and the sites are doing all of the clinical workup. They're doing the testing as soon as they have a diagnosis. That information is shared directly with our clinical pharmacist. We're doing the recommendations on what to treat the patient with as soon as that is finalized. And we actually will enter the prescription in our electronic medical record. The provider just signs off on it. Once we get it back, we begin the process. And that gives our in-house pharmacy the first ability to fill that prescription before it gets transferred out to a specialty pharmacy or a pharmacy of the PBMs of choice. Because of that, we're capturing about 50% of all of the Hep C prescriptions that are being prescribed by our organization. We currently have 47 patients that we are in active treatment, and that has been pretty steady for the last 6 months. We were increasing quite a bit because we were adding on sites, and we haven't added an additional site in the last 6 months. So, the great thing about hepatitis C is that it's one of the few things you can cure out there, and talking about changing the entire attitude of a provider when they can actually cure something. I get emails all the time from our clinical pharmacists after we get back the final lab work saying it's gone, and they're all excited. So that's good. Well, and that service migrated pretty easily over to our PrEP program for HIV. First, we were working with a third-party agency doing this virtually. In the last 3 months, we have moved that in-house, and we have providers who are now offering PrEP for HIV. We thought we were going to have a little bit of lull before we were going to try to get into the treatment of HIV, but some circumstances have come up and opportunities for our organization where we can actually get into that sooner than later. So my guess is by January, we'll actually be treating active HIV patients in our clinics. We had one of our major hospitals had a site about an hour away from where the hospital is, and they're closing it down on November 5th. So we're going to offer that in their sites. We've just recently had 4 of our providers that came into our organization who've treated HIV in the past. The pharmacy, that will also be a pharmacy-centric program. We will have a pharmacist in each one of those sites where we're actively treating HIV. So again, for the same reason, if our pharmacist is there and we're going to be doing the prior authorization, we would be the first opportunity to fill that prescription. Of course, we can't steer patients to your pharmacy. However, I don't think a CVS pharmacist is going to spend an hour or Walgreens or Walmart, or you name the big box store. They just don't have time with a patient. And if we will, that will help set us apart from those other pharmacies that the patient may be frequenting. We also have coordinated care, and the coordinated care program right now is not only, that's where we're actually going into the sites. And if we have a provider that's leaving, you could name this transitional care, but the reason we use coordinated care is because transitional care is typically a term that you see when patients are coming out of the hospital. So coordinated care, if we have a provider who's leaving and we haven't yet hired someone in or they haven't started, sometimes those patients will actually go on an island, and it could be from a month to 3 or 4 months, depending on when the start date is for the new provider. We started this with one of our providers who had retired. Our first case was 1,200 patients, and our pharmacist took that whole patient load over, and we called every patient, did a complete med rec, cleaned up their chart. If they needed a more acute attention, we had a provider that was on standby that we would refer those patients to. If it wasn't someone available in the site itself, we had a provider on standby that they could host that patient in some type of an appointment virtually. That has been such a success for us because guess what? Every time our pharmacist talks to somebody, they also tell them how great our in-house pharmacy is. We tell them about the services that we have. We make sure that they know we're going to be able to spend that time with you that you may be wanting right now at your local box store, but you can't get. And in the last 3 months, we have also taken over all of the prior authorizations for an entire organization. If you want to become a fan of your providers, take prior auths off their plate. They hate them. The nurses hate them more because they're the ones that were typically doing them. So we're now conducting all the prior auths regardless of what the prescription is. And while we're doing so, we ask the patient if it's okay, if they're not a patient already of the pharmacy, for expediency's sake, we would like to go ahead and once we get the prior auth, fill it and send it to you today or that day so that you can, there's no lapse in you being able to get the medication. Again, with us mailing that out, we know that we have to allow for 24 hours. That's the typical turnaround time or delivery time that we have once it hits the mail. And then, of course, we did medication, therapy management, and outcomes. That's where all of our clinical pharmacy started. We wanted to become good at what we were doing. The same thing, no different what Karen was saying earlier. Every time that our pharmacists or our technicians have an opportunity to talk to a patient, we are endorsing our in-house pharmacy. And then on my side, just to see what that impact is, we have a way of coding it inside of our system that this was a clinical pharmacy patient. And then we can run those reports and see, well, what's the financial impact on the pharmacy because clinical pharmacists talk to someone. It has nothing to do with billable encounters, which we also track. We track the annual wellness visits, which is a billable encounter, and also chronic care management. But we can just run those reports and say, hey, just because our pharmacists have talked to these patients in the clinic, we're now filling those prescriptions. And I give clinical pharmacy credit for that when I run those reports. Next screen, please. So the first step that when I ask about this is, how do you grow your in-house pharmacy business, your capture rate? And the first question you always have to answer is, who are you? What is it that makes you, you? Why is Central Virginia? Because Central Virginia Health Services Pharmacy is going to be different than Jericho's pharmacy. It just will be, right? There's because your pharmacy is typically, and what you offer is a reflection of the needs of the community or your patient population. So that's the first question you always have to answer, because if you don't know who you are, you won't know how to promote yourself to be able to capture those prescriptions that you're currently losing. So for us, I won't go back through those on the screen, but you know what we're offering clinically. So we know that we already offer those things. So we know who we are. In the pharmacy operations offerings, we have a sliding fee discount, right? They're not going to get that at a retail pharmacy. And we also know that we have the ability, because we participate in a 340B drug purchasing program. Next screen, please. So I always start off, with a spot. That is, what's your organization or your pharmacy strengths? What are your weaknesses? The opportunities that you may have, and the threats. So under strengths, just specify what your business strengths are. What is it that you are really good at? Maybe you're really good at talking to, counseling patients on their medications, because we may have a little more time than the regular retail pharmacy. I came out of big box retail for 23 years, and as much as I wanted to practice clinically, there's only so much time in the day when you're giving 70 flu shots, filling 350 prescriptions with 3 technicians. Unfortunately, the environment will dictate how well you can offer those services. In what way are you better than your competition? Well, there are a couple of ways, and we'll get to those in a minute, but you want to define that. And then your unique technical and professional skills in your business, what do you possess in that? So there are your strengths. On your weaknesses, just try to figure out what is it that we don't do very well. Because you may want to stay away from those areas, or either you may want to utilize some additional time to become better in those areas. And then opportunities, that is what's out there, what is not being captured, where is and I hate the term, it gets overused, where is the low-hanging fruit? Right, so we can actually go after that. That way, you see success in your prescription building process. And then, what are the threats? So, what are those things that are out there that you may have to be cognizant of? It could be, as we started talking about earlier, it could be the threats that we're seeing with 340B right now. Right. Next slide, please.
Hey guys, just FYI time, just keeping a track of our time. We're about 10 minutes left, so we want to make sure we get to our next speaker as well.
Okay, I'll get right out through there. All right, so some of the strengths, 340B, right? I can purchase a drug cheaper than what they can at the big box stores. Our location, hopefully you have a pharmacy that is in close proximity of your clinic. If it is in the clinic, you want to make sure that it is on the way out of the door. Right. So you don't want them to have to go to a different location in the building and then have to turn around and come back. So you want to make sure that they're passing by that location on the way out. We have access to the EHR. That is probably the biggest advantage we have over the other pharmacists. We can see everything. If there's a problem, we can see it. If we need something that's more immediate, we can actually queue up a prescription, send it to the provider, let the provider look at it, and send it back to us. The providers work for the same company. If your providers aren't promoting your pharmacy, then you need to bridge that gap between you and the providers and find out why is it that you're not telling folks to use us. It could be that they live a long way away. I don't know. We have the participation in the prescription assistance programs. We have sliding scale prices, right? They can't get that. And then, of course, the prior authorizations, which we can streamline. Next slide. Some of the weaknesses, we have a lack of buying power, right? Outside of the 340B program, our non-340B purchases, we have a lack of buying power, so we can't compete with some of the pricing that you may see on those drugs at a bigger box store chain. Location, it could be that the patient may be coming to your site, but they live 30 miles away. They don't want to wait the 10 minutes or 15 minutes to get your prescription. We'll just send it to the other pharmacy and it'll be ready when I get home. So that may be one. PBM restrictions, right? They could keep you out of networks. And then your hours of operation. Most likely you're not operating 12 hours a day and 8 hours on Sunday like most of your big box competitors. Next slide. And then your opportunities. We've run similar reports to what Karen had mentioned, and there are 2 schools of thought on opportunities and prescriptions, and it will depend on your organization. But one of them is I want to capture every prescription we write, right? I'm greedy, I want them all. that's one school of thought. The other one is I want a targeted approach. I want to capture prescriptions, but I want to make sure I'm spending my time and effort and dollars on capturing the prescriptions that make the biggest impact in our organization. We fall somewhere in the middle on there. And what we would do is we'll go out and we'll start targeting those things that we've already seen as a threat. So, for example, I'll put up here capturing 340B savings being restricted at contract pharmacies. We, on the reports that are listed below, we went out, ran that report based on the NDC number and what who the manufacturer was. And then we saw those patients. We targeted those patients early on when we found out that we were losing the insulins through contract pharmacy. We called the patient, let them know what was going on, and offered our services, and we would mail them out to them. The other would be on a diagnosis code, because on diagnosis codes, you can pretty much assume that based on the diagnosis, that they're going to be on a prescription that's going to be expensive. Very few patients out there are going to have diabetes flat, right? They're going to have diabetes and one or two other disease states that go along with it. So we'll run those as well. And then where are they currently going to get their prescriptions? Because we want to know that, because that may dictate whether or not what our approach is to advertising our pharmacy. Next slide. And then some of the threats, restricting the number of times you can fill a chronic medication by the insurances and PBMs. We see that all the time, right? They get the original plus one refill, then they have to go somewhere else. That's one of those issues that may be a threat to the pharmacy. The other be predatory payer contracts, especially on 340B, right? So that would be something to be cognizant of. What's the wait time versus the travel time? So if your wait time's 20 minutes and I live 20 minutes away, I'd rather be waiting while I'm driving, right? So we need to figure out what that looks like. Lack of non-340B purchasing power, and then just your network restrictions where they're just not allowing you in the network. Next slide. Oh, that's it. So I'm sorry that was quick, but I want to make sure we have time for Keith.
Hello, everyone. I'll try to also be quick here. I'm Keith Sinead, Vice President of Pharmacy Services here at Health Point. Just a little bit about our centers. We're in the western region of Washington State, roughly 80,000 patients, 19 service locations. There's the services listed below, very similar. Pharmacy, we have on-site located in the medical centers, clinics, and we have one central refill and call center pharmacy. We also, like David, have a specialty pharmacy. We do about close to 300,000 scripts annually. We generate about 27 million for our organization and about 15 million in operating margin. There's a lot of things that we've been focusing on, many of which David and Karen talked about, and there's going to be some similarities, but the three just for today I'll talk about is the mail and home delivery, and then the specialty, and then the patient engagement. So we started this concept back in 2016 when we surveyed our patients to determine what kind of demand there would be for this kind of service, and of course it was very highly valued demand. And so that we started with the free mail. It's always been free. And then during the pandemic, and also because we got some input that they didn't, having the mail delivered to some apartments was very sketchy, and people didn't want it, but they did want to have home delivery. So we added that service in 2019. Next. So the results were from 2016 to what we're projecting this year, about almost 80,000 scripts mailed. Home delivery that we started this year was probably approaching 250 to 300 episodes. We're doing close to 300 scripts a day. Average cost is about $225 per prescription. And of course, the benefits for us that we see are, again, repeated, same with David and Karen, it's convenient. A lot of our people are on our adherent programs, and we feel it's a real good retention. Just as was mentioned, we can't be a Starbucks and open 24/7 kind of thing, but just like Amazon, you can, if you can't come to, you can't go to them, then they, go to, if they can't come to you, you go to them. Next slide. So our next step in this process is we're going to go ahead and add another courier delivery person so that we can do more of our own home delivery versus the two other vendors that we also partner with. And then to take a time off and do some process improvement, look at leveraging technology. And believe it or not, we've been doing this since 2016. There's still people internally and externally, some of our providers that do not know we provide this free delivery service. So we'll be working on that this year and next year. Next steps. Okay, next slide. So like David, we have a specialty pharmacy as well. How did we get started with this? Again, like David, there was a Hep C clinic that was started a while back, and that kind of let the primer for us to do that. But I've been sort of studying this, area for the last 15 years. In fact, I'm here at a specialty conference in Vegas, and following the market trends. It's just that's the direction this market is going. So the other thing that we did in planning was we have the Community Health Plan of Washington is one of our major Medicaid plans, and we approached them about patients that are assigned to HealthPoint to be allowed in a limited network, and we were successful in getting that allowance. So the proposal was to start a separate licensed specialty pharmacy because there was going to be some investment. Can you go back this one slide, please? And there's going to be investments in accreditation. We were ACHC accredited, but we're also, like David, going to URAC as we stand. We're going to be adding staff, IT infrastructure, facility design. Next. So the proposal was adopted, and then we had to go into a full business plan mode and build a pro forma. That's just an example of the one that we did. Next. And so the deployment part was we did separately license the specialty pharmacy. We separate NCPDP, NPI numbers with the taxonomy codes listed as specialty. That was helpful. We were able to co-locate within central fill, so that reduced the expense of build out. We also work with QS1. We're now with Liberty, but we had to buy a separate software, and then we also had a clinical management software, Ascendia, that we purchased. New insurance contracts, new job descriptions. We hired a pharmacy manager and one technician to get this started, and the accreditation process was initiated. Next. So real quickly, this is the results from 2019. That full year was about 6.8 million in revenue. We're probably going to go over 12 this year. And as you can see, the number of prescriptions is not real high, and that's the same with patients, but the revenue per script is extremely high. Next. So our next steps is that we are in negotiations with our employee benefit part of our insurance. We're going to ask that they allow us also to be part of the restricted specialties, so we'll be filling for our employees. And we also have been approached by a local employer about doing that for their patient employees as well. And we started, we have the ability now to do non-340B. Next. So this last model is very similar to Karen's. We call it a patient engagement specialist, and it was modeled after Equiscripts when they would constantly try to get their business. So we piloted it during the pandemic because we had someone that had to work from home, same circumstances. And then we worked with our plan partners to get claims data that to help us target who we should go after. Again, very similar approach, but just kind of a back end than what Karen's doing. Next. And this is an example of what one of the plans just sent us. It's you get the drug, you got the expense for the plan costs, where it was sent, etc. Next. And then our pilot person just did a very basic tracking form that helped her do her workflow management. Next. And the pilot we felt it was successful enough to go the next steps, and it was about almost $900,000 in annualized revenue from the main three providers. So we put together a proposal. It wasn't a big investment. This is just for person. So we put that together next and developed a specific job description next. And this is an in-house developed. We went from that spreadsheet to something a little more formal. That I developed this to help her be more focused on where these claims are in the process, and that claim data that I showed you from the insurance. This gets uploaded into this database automatically, and then she just works the claims. And we hired her in May, and she is a technician. Some of the same things Karen was mentioning is why we went with a technician. I won't go over it again. But since May, she's annualized revenue pullover has been about 1.2 million. Next. And next steps are for us to continue to refine and improve the data collection. We talking about expanding the scope for patients that we know transfer out. And then also our EMR has the ability to tell us where providers are sending the patients, and that's another area that we think she could begin starting to do outreach. And I think that's it. Yep.
Awesome. Thank you, Keith. Thank you, Karen and David, for some highlighting the work that you guys are doing at your organizations. And I see, there's been some questions coming in and out. And thank you, Karen and Tim, for kind of answering those questions as we go. Sounds like you guys were able to capture some resources from our panelists. So tell you what we're going to do to kind of expedite the questions. Oh, I see Byron just responded. Okay, gotcha. Thanks, Byron. Brian. So I wanted to get the folks who raised hands first. Brian just accidentally hit that. So I'm going to offer Sarah an opportunity to ask her question. And Olivia, if you can unmute her. And while Sarah's asking her question, if our panelists can take a look at the Q&A, and if you can type in some answers if they're relevant, or if you can provide a response, we can kind of expedite questions simultaneously.
Hi, Brandon. I think Sarah may have actually just put her hand down. So Sarah, if you do want to ask your question, just go ahead and put your hand back up. But it may have been an error as well.
Great. No problem. And I see that Ray just made a comment in the chat. So yes, we will make sure the slides are shared with everyone. And there will be a recording, as Olivia mentioned at the beginning. So that being said, I will pull up the Q&A while we have just a couple minutes. I know we're over time, so if you can stay on, please. I see Tim has answered some questions. So just everyone take a look at the Q&A. You'll see the questions have been answered. And I know one question just popped up. Is anyone aware of any PBNs restricting MTM's reimbursements to FQHCs? Panelists, feel free to share vocally if you'd like to.
There certainly are some pretty terrible contracts that are out there within the FQHC world if you're a 340B provider. So you have to be aware of that. And because the difference is, one of the contracts that comes to mind, I won't mention the name of the company, but you have most contracts that you receive are annual AWP, average wholesale price, which is fictitious, minus some percentage plus a dispense fee, which is anything from $0 to $2, which really doesn't exist, right? So, but the one that comes to mind is that they don't use AWP, they use WAC, which warehouse acquisition cost. And that also is not exact, but it's a lot closer to what we pay for those drugs than what AWP is. So that one that we were talking about yesterday in a meeting was warehouse acquisition cost minus 31.25%. That's getting really close to what we're actually saving on the prescriptions, purchasing them 340B. So that's one example of one that it's a really bad contract. But if you want to participate with them and you're a 340B provider, that's the contract you get. You just have to be aware of it. As far as a restriction, I haven't heard of any being restricted right now where they could not participate. Now, if you're only 340B, you're going to have a hard time if you're trying to get into a PSAO because from my understanding, most PSAOs are still retail accounts only.
Great, thank you, David. I see one question here that popped up. Kimberly, I don't know if you were relating that to Keith, but any panelist can certainly answer. What's your average cost for free delivery?
In my slide, it was, it's not up now, but it was $250, something like that. When we started, it was less than, it was like $1.75, but then when we started adding the more costly delivery options, it jumped up to about $225 per RX.
Great.
Brandon, there was another question I thought was pretty important. And one thing I want to mention, I apologize to folks during the Keith's presentation. Olivia's slides were being wonky. She wasn't trying to rush Keith in any way. And I just want to make sure Keith knows that and everyone else. It was unintentional. We all know how electronics are. But there was a good question about mailing prescriptions to patients with insurance. Have any of you had any issues or concerns? Because we all know our PBM contracts like to tell us that we're not supposed to do this. How have you folks gotten around that, or do you have concerns with it?
I can add to some of that. Yes, I have concerns with it. Since COVID, before COVID, we were averaging just south of 25% of our prescriptions being shipped out or mailed, if you will. And since COVID, we're now over 65% of our prescriptions are being mailed. And right now, during the pandemic, we have, I think everyone's gotten a get out of jail free card. As soon as the pandemic lifts, my guess is that knowing the PBMs and their interactions with me anyway, I would expect that to go away. So that's one of the reasons why we got our URAC accreditation for mail services. That would probably require another contract, but I just don't see our patients not in the masses that are going to be needed to drive us back down below that 25%. And that 25% is, I guess that's the lowest one that I know. I think the highest that we have is we have one contract that says you can't mail more than 30%. But and then you have some out there that say you can't mail at all.
CVS says you can't mail at all. So yeah, that's a problem.
Yeah. So Optum says you cannot. And when you get credentialed or you do your reaccreditation with those folks, they'll say, "Do you mail prescriptions?" And if you answer, they say, "Do you know you cannot mail prescriptions to Optum RX patients?" So they ask you that 3 times. However, I was able to get a waiver from Optum RX for all of our pharmacies to mail prescriptions, which is like gold. We have that saved in many locations, but we were able to get that because we were an FQHC.
Okay, guys, I appreciate thank you for the answers and amazing presentations to all our presenters, David, Keith, and Karen, and Tim, for your assistance with pulling this session together. I don't want to hold people too much longer, but if you have any additional questions, you do have Tim and I's emails. You see those there, and Tim and I can certainly facilitate getting those questions to our speakers, and we can get responses to you over the course of the next week for you. Thanks again, everyone. We still have so many online. We really appreciate you, sacrificing some of your additional time to stay online with us. Again, additional questions, shoot those our way. And also, more importantly, if you have any focused topic ideas that you'd like to share, or you want Tim and I to kind of work on developing a session, please forward those to us as well. We're always looking for those. And as Olivia mentioned at the beginning, evaluation link will be shared. So we strongly encourage everyone to submit your responses for those evaluations. All right. Again, thank you to all of our speakers, and thank you to everyone who stayed on board and listened, that were engaged with today's session. We hope you enjoy your afternoon. Take care.
Thanks, everyone.
Thank you.
Bye, everyone.
Thank you. Bye.